They seem to be slowing down now. If you want to go ahead and start, I think you're okay. There's one more here.
Perfect. Thanks, Peggy. All right, if you want to start recording now, that would be awesome. And go ahead and mute everyone. Welcome to this session of the 2026 Culture of Data Conference. Thank you all for joining us. My name is Katie Hammond. I use she, her pronouns, and I'll be moderating this session. We also have Peggy, who uses she, her pronouns, and she will be managing the Zoom and making sure that tech is running smoothly. Peggy will mute you all now, but if you have a question during the Q&A sessions, please feel free to unmute and ask. You can also use the chat box if you have questions or need anything throughout the presentation. We will be monitoring it. If you're comfortable doing so, please add your pronouns next to your Zoom name by clicking the 3 dots on the video square and selecting rename. I now have the pleasure of introducing our session sponsor, Connect for Health. I want to acknowledge that we would not be able to deliver such wonderful programs.
Oh, Katie, you're on mute. Oh, there you go.
How about now?
You're good.
Perfect. Thank you, Ben. All righty. So welcome to this session of the 2026 Culture of Data Conference. Thank you all so much for joining us. My name is Katie Hammond. I use she, her pronouns, and will be moderating this session. We also have Peggy, and she will be managing the Zoom and making sure that tech is running smoothly for everyone. Peggy will mute you all now, but if you have any questions during the Q&A session, please feel free to unmute. You can also use the chat box if you have questions or need anything throughout the presentation. If you are comfortable doing so, please add your pronouns to your Zoom name by clicking the 3 dots on your video square and selecting rename. I now have the pleasure of introducing our session sponsor, Connect for Health. I want to acknowledge that we would not be able to deliver such wonderful programming without their support. So thank you, Rachel Peters and Danny O'Neill. And thank you again, Connect for Health, for everything that you do. We have one presentation during this session. They will present for approximately 25 minutes, and then there will be 10 minutes for Q&A afterward. Broomfield Public Health and Environment started a health ambassador program to improve Broomfield's health by ensuring equitable access to health education, resources, and services for focused populations. I personally really look forward to hearing more about this program and its impact on the community. I will now turn it over to Sarah Torres and Sarah Mock to present Evaluating the Intangible, a Health Ambassador Program Impact Assessment. Thank you.
Sorry, real quick, presenters. Did we have some folks, are our sponsors online?
Yeah, I'm here.
Oh, Rachel, do you want to go ahead and say a few words at this time?
Yeah, I would love to.
Okay,
Hi,
thank you.
everyone. My name is Rachel Peters. I also use she, her pronouns, and I am from Connect for Health Colorado. We are the official health insurance marketplace in Colorado. Our mission is to increase access, affordability, and choice for individuals and small employers purchasing health insurance in Colorado. Our teams work with community partners across the state to help connect Coloradans with state and federal financial help to get Coloradans covered. This year, our 60 enrollment center locations served Coloradans from all 64 counties, and our community outreach team partnered with over 600 trusted community leaders to connect with Coloradans in their communities. We are so appreciative of this network of thought partners and the work that you all are doing to leverage data in ways that are thoughtful and that serve our communities. Thank you so much, and I look forward to another great session.
Thank you so much, Rachel. And Sarah, do you want to take it away?
I sure can. Hi, I'm Sarah Mock. I'm with Broomfield Public Health, where I'm our health planning and systems manager. And Sarah Torres is really the brains behind all of this and the heart as well. So she's our data analyst for the health department. I'm going to just start us off with a little introduction to who we are. So in case you haven't found us on the map, because we're tiny, we are the little red dot up there that the arrow is pointing to. We're the smallest county, both in terms of geography and population in the Metro County. We have about 76,000 residents. I'm sure our demographer from this morning has an exact number for us that I'm not going to try to pull up right now. But we do have the majority of our residents identifying as white, with about 14% of our population as Hispanic and 7% as Asian. We mostly speak English, and I'm providing this context for us because of how our health ambassadors are selected and work within our community. So bear with me. But we do have a lot of language diversity in our community. That being said, most of our individuals who do speak another language at home other than English are reporting that they do speak English very well as far as census data goes. We are also an aging community. The fastest growing population in Broomfield is those who are 65 plus. Shout out to my parents for moving here a couple years ago and helping that statistic. We, economically speaking, are fairly well off as a community. I think that's a pretty standard presumption about Broomfield. Our median, about 40% of our households do earn over 150,000 a year, but we are seeing an increase in unemployment rate, and there's also a self-sufficiency standard that we like to use in terms of what is the real cost of living versus the federal poverty limit. And we do see that gap growing in terms of what it costs to actually live in our community versus what people are earning, growing consistently across the years. Housing stability is also a growing concern in our community. There's a lot of movement around this within our different organizations, including our faith-based community, to address housing stability. One of the things that we use as a measure of this is the number of students identified as unhoused through the McKinney-Vento Act in the most recent school year available. So it's over 200 students. So a lot of concern around those youth particularly. And I have to find my mouse to move through the slides. So, okay. What is this Health Ambassador program that we're talking about? This is really, like, I guess, if you will, our origin story is from COVID, of all things. We saw, like most communities, that COVID impacts were being felt most acutely in our minority communities. And as vaccines were becoming more available, we didn't want that inequity to continue to perpetuate across the different populations in Broomfield. And so in order to encourage and educate around vaccines and enable access, we recruited a group of local community partners. We had a Baptist church with a primarily Hmong population. We had individuals who serve through our food bank, through our Hispanic population with a group called Collectiva, engaged as individuals who could reach deeper into the community to connect with the people that were in their networks to bring them into the vaccine conversation, whether that be in an education sense or a literal, let's bring you to the First Bank Center and get you vaccinated. So a little bit of hands-on education and work there. So fast forward a few years, we saw this have an amazing success. We had one of the highest vaccination rates within the metro area, and wanted to really expand on this model for other health topics. We are the holders of our opioid settlement funds as the public health department for our city and county, which is a little unusual. But when we talk about behavioral health, we know that this is a highly stigmatized topic area. And we wanted to use this model to engage with our local partners around how do we bring this topic of behavioral health deeper into communities. And so this has really become a way of doing business for us in terms of how we engage with our community partners. So far, we've ranged from having 9 to 12 funded partners. I do want to emphasize that this is a paid contractual relationship, that people are compensated for the work that they are doing with us. But it also brings a component of wanting to know how well this program is working, because it becomes up for renewal when we redo our opioid settlement implementation plans. So we want to be able to emphasize with our community that reviews this plan that this is an important way for us to engage with the community. So who is a health ambassador? I think that this is an important point on the slide, is that it can be a person, so an individual with lived experience, or an organization who is not typically involved in public health. So I mentioned a Baptist church with a Hmong population, not somebody that you typically see in the health department meetings. We also have individuals with lived experience who are an amazing partner and reach into the communities in ways that I don't know that we could possibly achieve without their assistance. So it's really neat to see this working. I'm going to explain a little bit about the data side of this, the analysis. The goal of the Health Ambassador Program is really to improve Broomfield's health by ensuring that we all, as a community, all of us, even those of us who may not be typically captured in the data, have access to health, education, resources, and health services. So really down to those core public health services. And the question that we were asking is, does having this Health Ambassador Program improve that access to health education, resource, and services, particularly around our focus populations? And then, very much in line with the first session this morning, is what is it that we are missing when we do the typical data process analysis around, like, what are your process measures? How much did you do? When did you do it? Who did you reach? We wanted to also look at some of those other components of what does it mean to have trust and build health equity? How do we share power? How do these relationships continue to benefit across time? Are they sustainable? And those aren't things that we're going to find in our typical survey data sets. So hence the implementation of a social network analysis. And this is where I get to turn it over to Sarah, who designed the study and is going to walk us through the results.
Thanks, Sarah. So when we started the process of trying to figure out how to measure the impact that this program was having, we came up with these 4 questions that you see on the what. And we decided to do this impact assessment using a guided survey approach, where we looked at the knowledge of the services that we provide, and we captured the structure and function of the network of the health ambassadors. We will go through each of these questions of what the assessment measure. But first, I want us to know a little bit about what this looked like. So this was a pre and post study, where in the pre-survey, we got to talk to 11 out of the 12 health ambassadors and the public health staff that was working with them. This was done during January 28th through February 6th of 2025. And then towards the end of the year, and before they knew the results on whether or not they could be health ambassadors for this next cohort, we interviewed them again, asking the same questions. In the post survey, we had a participation of 10 out of the 12 health ambassadors and the public health staff. So we're very excited about those numbers. So don't worry about the questions in purple. We will get to those in a minute. But first, I wanted to discuss how we captured this knowledge of service and resources provided by the public health department. So to understand if there was changing knowledge, is our program helping change the knowledge of services and resources provided by the public health department? We asked them at the beginning and at the end, how familiar is your organization with the services provided by the local public health agency? And what we found was the biggest increase in familiarity came to our mosquito control program. And then, not surprisingly, the immunization clinic didn't have a lot of change given the roots of this program, right? This comes from the immunization ambassador. So all of them kind of had some familiarity there, but we have mosquito control, waste management, birth and death certificates. Those were the biggest increases in familiarity. Overall, there was an increase in familiarity for all the programs that we provide. So now on to the next 3 questions that we had. This is where social network analysis was very helpful. So we looked at the expansion of the network for the health ambassadors after 1 year of participation. And for this, we used what's the density of the network. We also looked at the diameter and average of the paths to understand the information pathway. So this second question is the pathway of information between BPHE to the community at large through the health ambassadors shorter after 1 year of the program running? And then for the next question, are there significantly more connections between each other, forming smaller, more cohesive subgroups? We used a metric for modularity to understand if there were subgroups forming. So before we keep going, I want to make sure we're on the same page about social network analysis, some basic understanding of what I'm talking about. So this is a method to analyze relationships between people and organizations. Those are the nodes. And whenever I'm talking about health ambassadors, that's the nodes in the network that I'm discussing. This method visualizes and quantifies how individuals connect and interact. And those connections were measured in terms of collaboration. So it was always asked about, do you collaborate? Is there a collaboration relationship? Okay, so to identify who they were connected to at first, we asked for each of the health ambassadors about their relationship with each of the other health ambassadors. And at the end, we asked, are there any other organizations you work with for the Broomfield population? You have the option of adding 3 more organizations to the list. And we ask that if you're choosing to add organizations, they are ones that you interact with for your work mainly within the Broomfield community. When we asked this question, we found that there are some organizations that were identified by 2 or more health ambassadors, and then there were some organizations that were dropped after the pre-assessment. So were mentioned at the beginning, and then in the post-survey, they were not allowed to add anyone in the post-survey, but those organizations that had added these ones decided to not, they were no longer in relationship with these other groups. So now I want us to understand 2 main terms that helped us get into these metrics. And the first one is this betweenness centrality. So understanding the bridges, gatekeepers, but also the bottlenecks of the information. These groups may not be the biggest all the time, but they are the ones that are connecting different groups to each other. This matters because these groups ensure that there are no islands, but are also the ones that are holding the power to connect the groups that are around them. The next term is the eigenvector centrality. These are the power brokers. This is the identification of power brokers. And this is not so much about how many people you know, but who you know. So it matters who you're connected to, because the more connected the person you know is, the more relevant you become. And I know that I'm going to be saying words like relevant, powerful, popular. This is nothing to do with our social construct of that. This is plainly about number of connections and how well connected you are within a network. In this case, I want you to notice that the red point, that's the highest eigenvector centrality. That node has 3 connections, but each of those connections has more connections in general. If we look at the one that Sarah is about to mark, that one. That node also has 3 connections, but those 3 nodes are not really much better connected than its own. Therefore, the eigenvector centrality of that one is lower than the red dot. Okay, so for this study, we measured first the overall collaborations. Sarah, ooh. We keep the circles. This is great. We'll get there. We've measured first the overall collaborations, and then we measured by topic the collaborations that were happening. So let's start with the overall collaborations. What we learned about the network is that each organization, we'll get there. Yeah, there we go. Each organization went from interacting with 4 or 5 of the other health ambassadors to interacting with about 8 health ambassadors, indicating growth in each of the health ambassadors network. The total collaborations increased from the 38% of all possible connections to 83%. The overall betweenness centrality was decreased, and that is how we're able to identify fewer and smaller bottlenecks for information and collaboration opportunities. This is a good thing, that the betweenness centrality scale went down. We still have some bottlenecks. We still have some organizations or individuals that are kind of like our biggest intersections of information, but that scale has decreased, and the connection between the health ambassadors has increased as well. So this was great news. And then we looked at power, thinking about our eigenvector data, showing that inner circle of our community network has expanded and strengthened. Previously, influence was concentrated in just 2 or 3 of the large organizations. Post-intervention, we see a solid block of organizations sharing near perfect influence scores. And this includes grassroots groups, individuals who have moved directly into the core of our program or of our network, which means that it's no longer just the biggest institutional players, the ones holding the influence in the network. And that's part of the aim of our program. So for us, data people, we'd like to see that in numbers. So there is a table, and we talked about density. That's the 38% versus 83%. We see that was an increase. The diameter, so the longest chain of connections, decreased. That means we need fewer steps in between our network to pass information along. It started with 3, now it's 2. And the average path length, so on average, it just takes 1 health ambassador to get the information to, so they can reach out to each other fairly easy. The only metric that did not move as expected for us was modularity. And if I'm absolutely honest, I think that this just has to do with the stage of the network that we're in. Modularity tends to grow as the network matures, and it creates these smaller subgroups that allow for specialization, and in that regard, help boost the collaboration by allowing those who know more things kind of to group together and kind of help everyone else around them. But overall, we have a group that is moving together towards common objectives. It's leading to a more resilient community overall. Now, I mentioned that we also did some specific collaborations. So we wanted to do the networks thinking about the goal of the health ambassadors. So if you remember at the very beginning of this presentation, we had that we wanted to improve access to health education, resource sharing, and service provision. And then you also might remember that our funding has to do with opioid awareness, the opioid settlement. So when we decided to ask for each of these topics, what was the network like? So looking at the topic-specific collaborations, we found similar changes in the network that are reflecting a stronger, more collaborative network than the one we started from. In terms of collaborations, we see higher number of collaborations and a higher proportion of collaborations. In terms of information flow, we observe shorter pathways that are displaying stronger cohesion and more efficient collaboration. The fact that the control that Broomfield Public Health has decreased is a win. And I want to make sure I say that, because my coworkers, every time I'm like, oh, we're a little weaker, they're like, well, that doesn't sound great. It is good. It's good that we're not holding the reins of all the information and that our health ambassadors are not depending on us, because this will help us provide a more resilient network that the day we cannot engage in certain conversations, they can, and they can carry forward the work. And again, I am giving you the numbers for that. As expected, the metrics moved in the direction that we expected them to move. The only metric that didn't change was modularity. And again, especially when we look at specific topics, it is normal that modularity didn't quite change or decreased in this case. We just are becoming one big, strong network. Okay, the other part of this is who are we reaching and how are we doing with that? And in the pre-survey, most collaborations sought to serve cultural minorities. And then there was a shift after a year of programming towards youth. But notice the number of collaboration. In the pre-survey, our top group was the cultural minorities, and there were 36 collaborations to reach out to them. And now in the post-survey, it was youth with 66 collaborations to try to reach out to them. So it is shifting, but most importantly, there is more collaborations for each of these priority populations to be reached out. So our key takeaways: the combination of increased collaboration and balanced eigenvector scores, it's indicating that we have a resilient, decentralized network, which means we are sharing power. The diversity of communication paths is ensuring a robust collaboration, preventing single points of failure. The only metric not optimized across the board was modularity. And I suspect that if we were to do this study in a couple of years, we might see some modularity happening. We strengthen targeted working groups to ensure expertise can be developed within subgroups while maintaining the cross-group collaboration. We can kind of accelerate the process of those subgroups, but it's not necessary. We think that that will come with time. And finally, by us prioritizing the relational depth over numerical reach, our evaluation hopes to capture the structural resilience that output metrics may overlook. Thank you very much. And I am excited to hear questions.
Awesome. Thank you so much, Sarah and Sarah, for the wonderful presentation. That was really interesting, and I'm really impressed. We're now going to go into our question and answer time. If anyone wants to unmute themselves, you're welcome to do that. You're also welcome to put questions in the chat, whichever works best for you. Ben, do you have a question?
I sure do. So thank you so much, Sarahs. You kind of alluded to this on the last slide about this kind of idea of breadth versus depth. And I was thinking about just in general, is there any established relationship between the number of collaborations that you have and the quality of those? Because I'm just thinking, you only have so much time in the day, and obviously it takes time to cultivate relationships and maintain them. And perhaps that was included in the analysis itself, and I just didn't quite understand it. But like, is there in general a trade-off, or is that kind of a false thing that I'm setting up?
So I don't believe that it's a trade-off. We took measures of trust, and what we did find is trust increased between the two times. I didn't put that wasn't part of the presentation. You didn't miss it, but yeah, I don't think it's one or the other, not at this level. We're talking about 12 health ambassadors. So not yet, I would say that.
Sarah, we do have a few questions in the chat. The first one says, this is a really awesome analysis. Did you see an increase of service utilization during the pre-post analysis as well?
I can take that one. I think we're still assessing whether or not the service increase, I think we're talking about things that are directly delivered through the public health department, if I'm understanding Sammy's question. And that is data that we haven't looked at quite yet. It is on the to-do list of things, but we are seeing an increase in things like uptake of our naloxone distribution boxes, attendance at training. So things where we wouldn't necessarily, we're not a big health agency. We're 33 when fully staffed. So when we compare ourselves to like Adams County, we feel very little. But that also sort of indicates how much service we can directly deliver. Like we don't have an immunization clinic every single day of the week. So we're kind of working on what that looks like, but we are seeing more increase in the things that are less appointment based in that sense.
Thanks, Sarah. We had another question by Trish, which it looks like you answered, Sarah, asking about the software used. Is there anything else you wanted to add about that? It looks like you responded.
Yeah, we used Gephi. That was the biggest part of the graphic analysis. We used a little bit of R. And then Lena asking about the time that it takes to complete the pre and post test. Yes, it took an hour. Each meeting with each of them took an hour. We designed it at first as a survey, but we're hesitant to send something like this as a survey. We have a great breadth of literacy in the group, and it was important for us to even out the level, the playing field, and actually be there and go through it with all the health ambassadors. I also think that helped create trust, but it was a lengthy process, and it's part of the reason it's not something we're constantly doing.
Thank you. I have a question. I was really impressed by how much familiarity increased regarding the mosquito control. I think it was about 63%, which is really incredible. Do you happen to know much about why that specific one increased so much or why it was so successful?
I have a hunch, and is that we had presentations. Like, I think this is a recently biased kind of situation. So the most recent presentations by different units of our department kind of show up as more familiar.
Yeah, that's
I
really
will
awesome.
add to that is just I don't think most people out in the community know that we have a role in mosquito control. So we started at 0 when it came to this one. So it is kind of a funny little like blip in the data. Like everybody was now knowledgeable about mosquito control. And just one thing that Sarah was kind of alluding to is that one of our goals had been to provide them with a basic understanding of what it is that we do as a public health department before like, hey, go do these things, or maybe understanding what we do so that they can build off of what we're doing or provide, more importantly, suggestions about how to do it better. And so we had to do some basic education for quite a few of the groups had never worked with us before. So it was important to say, this is what public health is. And there are some boundaries about what we can do, what we can't do, because we are, in fact, an extension of a local government.
Thanks for talking on that. That's really important work. Give it a few more moments. If anyone else has questions, feel free to unmute or write it in the chat.
I've got one more, if I can. So I love this social network analysis. I've never done this before, but seems like a really useful tool, especially for just trying to build coalitions, build partnerships, and like I think a lot of times, we think about that abstractly and we're like, that's valuable, but struggle to quantify like how valuable is that. So I love that this is a way to do that. I'm thinking a little bit about like the relationship between individuals and organizations, because we're kind of it's a little bit of both of those. And just this is totally anecdotal, but a lot of times, I will ask myself, like, who do we know at blah, blah, blah organization? And it's like, well, one of my colleagues has a really good relationship either with the org or with one person there, or maybe several. And so kind of what is the relationship? And then maybe that person leaves the organization and then the collaboration is gone because it really hinged on that one person. What are the kind of general relationships between like individual versus organizational collaborations? Could you speak a little bit about that?
That's a great point, and one of the hurdles of going through this process, because even between the pre and post, there were organizations where the person who filled out the first was not the person who filled out the second. So the bigger organizations actually brought in groups of people, and that was helpful. So it was no longer choosing one person and then making this decision. I think that those were the most consistent places where we found that they actually knew who they were connected to. We struggle with it even when we are trying to make an assessment of who we are connected to. But I think that that's the nature of connections, right? And the cool thing here is these groups vary. So some of these are actually just individuals. So yes, that is a weakness, and that's also just the reality of it for now.
Right. And just because that person maybe left an organization doesn't mean the connection isn't there anymore. It's maybe just a different node. So
A different
okay.
name.
Yeah,
It might be a different name, because we
Right.
also move around in the same ecosystem, right? Like it's rare that we just disappear from the network.
Right.
So
Thank you.
Thank you. Trish asked in the chat if we can see the slide with pre and post maps again.
that's a Sarah question because I can't share.
And then while you're pulling that up, we also have a question from Will asking, did you measure any other variables for each node, such as that node's influence according to the respondent?
We didn't yet. I am still playing around with some options of other metrics, but for now, at the node level, we did the betweenness centrality, eigenvector centrality. Those were like our two big metrics for now. And happy to hear if you have any ideas.
I can't remember who asked. Was it Lena who asked for the slide? Do you see it? Trish, sorry. Sorry, Lena.
I got it. Thank you.
Okay, yeah. It's really one of the best visuals, and we have been using it to really hone into our community partners, like how valuable they are and the success that they have achieved within this, because I don't want it to be missed that this is their hard work as well, and they're making connections outside of our Broomfield public health facilitated meetings. They're out there doing this work with each other on a regular basis. It's established relationships between organizations who had never heard of each other before, and it's allowing access to people in our focus populations to a wide variety of resources. So I think one of the things that I'll say is, like, in a very tangible way, we have an individual sitting at another organization during their client hours, receiving people, and vice versa. So there's this back and forth and ability to see this connection in real time. And it's amazing to not have to be part of that on a daily basis as a public health agency. And so we use this visual a lot to tell them what amazing human beings they are.
Awesome. Well, we have a few more minutes, so if anyone has any more questions, feel free to throw them in the chat. I do have a few announcements, but thank you so much, Sarah Torres and Sarah Mock, for presenting, and thank you all for attending this session and for engaging in the Q&A. The slides and any additional handouts that the speakers have provided are available on the schedule. You'll also receive a conference evaluation form during our sessions on Friday and via email after the conference is over. So if you can please fill that out, even if you only attend a portion of the conference, it's really helpful for the planning committee. We'll now have about a 15-minute break before the next concurrent session, which begins at 1:30 p.m. There are 3 sessions to choose from at that time, and you can see the full schedule on the Culture of Data conference website. Thank you again. And if there is any more questions, thank you all so much for being here. Thanks for the great presentation. We appreciate it.
I didn't need a 100-page email.